My name is Rositsa. I'm a senior researcher at the Health Economic Research Center. And yeah, okay.
Sorry.
Thank you, Kristen. And I'm going to talk about modeling the cost effectiveness of genetic test treatment combinations. And I'm going to use the example of extended DPYD testing in metastatic breast cancer. This presentation is based on the results of the HERC project that stands for Health Economics Personalized Medicine that we completed last year. Sarah and I were involved, also colleagues from primary care. This was a Horizon 2020 funded project, and we had partners and collaborators in the Netherlands, the Medical Technology Assessment Institute in Rotterdam, and also the Syrian Research Institute in Hungary. And hopefully this presentation will answer the question that Fred was asked. Genetic testing is expensive. What is HTA doing about it? Well, spoiler alert, sometimes personalized medicine interventions can be cost effective, and I'll tell you more about that. All right, and you've heard Fred introducing the concept of precision medicine, and I'm going to delve a little bit into it. So precision and personalized medical medicine technologies are used interchangeably. And when we talk about personalized or precision medicine, we mean a medical model that's based on the human genotype or phenotype. The information is used to screen, detect, diagnose disease, predict risk factors, tailor therapy or preventive measures. And the personalized medicine interventions are quite a heterogeneous group. So we have the gene and cell therapies, but we also have different genetic tests, treatment combinations, and we have tests that are likely to identify the responders or non-responders to therapy. We have the genetic test to screen or diagnose the disease. We have the genetic tests to gain information about disease prognosis. The DPYD pharmacogenomic testing in oncology is actually a test treatment combination that aims to evaluate the patients, to identify actually patients who can have an adverse drug reaction and subsequently modify the dose of chemotherapies in oncology. Now, before I tell you how we modeled the cost effectiveness, I'm going to give you a bit of a clinical background. Fluoropyrimidine-based chemotherapies, such as 5-FU and capecitabine, are approved for treating different solid tumors, including metastatic breast cancer. They've demonstrated proven benefit in terms of patient survival and are approved by NICE and other agencies. However, they can cause adverse effects due to the varying level of toxicities. And this is due to a mutation in the DPYD gene that causes enzyme deficiency and thus make patients low metabolizers. So standard dosing of chemotherapy can actually be highly toxic for those patients. So up to 15% of patients that are treated with capecitabine or 5-FU can develop severe side effects that can result in multi-organ failure or cardiotoxicity. So annually, approximately 10,000 patients in the UK are treated with capecitabine or 5-FU, and the amount of deaths can go up to 2% of the treated population. So what's the rationale? If clinicians are able to identify poor metabolizers prior to giving them chemotherapy, that will allow for dose adjustment, and potentially that can avoid severe adverse events. However, clinical practice is a bit more varying than this. So upfront DPYD genotyping is not universally implemented. Some countries, such as the Netherlands and France, have implemented it. Others have not, including the UK. And also there's a variation in how many genomic variants are tested for. So in the Netherlands and in France, they're testing for 4 genomic variants that are recommended by the Clinical Pharmacogenetics Consortium. And yet 50% of the patients that are treated with capecitabine or 5-FU still develop severe toxicity. So the idea behind extended DPOID testing is to look at additional variants. So the ToxNAV tests incorporates 3 of the 4 Clinical Pharmacogenomic Consortium variants, 15 DPOID additional variants, and 1 superfamily member variant. And in 2019, here in Oxford, at the Oncology Directorates, they implemented compulsory testing with ToxNAV prior to chemotherapy treatment. They implemented that as a safety measure for their patients. And luckily, we were able to have patient-level data for 466 patients that were tested with ToxNAV and subsequently treated with capecitabine. And we performed the propensity score matching, comparing those with over 500 patients that have not been tested with ToxNAV, but were given those chemotherapies prior to introducing ToxNAV. And this is largely the analysis and database that we're basing the modeling on. Now back to health economics. In terms of health technology assessment, we've developed a guidance for harmonizing and improving economic evaluations of personalized medicine. And I'm not going to go through the more mundane stuff, which perspective to choose and which discounting and what discounting rate, but I'm going to talk about implementing waiting times for test and turnaround of test results, and thus treatment, including in the model all downstream costs and effects that are associated with treatment selection, building in compliance, and that's from patients and from healthcare providers, and introducing managed entry agreements, and what is their impact on the cost effectiveness of personalized medicine interventions. Now, we built up a decision tree to look at the standard of care, which is no genetic testing, and everyone's given a standard dose of capecitabine. And we modeled also the testing strategy with ToxNAV, and you remember waiting times. So here we introduced waiting times into the model, and we were prepared to attach a decrement to utility, so quality of life, if there is any delay in testing, because it's evident from the literature and from clinical practice that delay of testing and start of treatment can affect survival. We're looking for our 466 patients. There were no delays, so everything was done within 2 weeks. And in the base case analysis, we couldn't look at waiting because there was no waiting. Now, in terms of building all in costs and effects, so once the patients were tested, they can have a true positive or false positive diagnosis of DPOID variant, or they can be true or false negative. And once they receive that diagnosis, they can be stratified by clinicians into having high risk variants that makes them more prone to adverse reaction, or having a hand-foot syndrome risk variant. And here I should mention that the Clinical Pharmacogenomics Consortium recommends that all people who have a high risk, they receive a reduced dose of chemotherapies, while all people who have hand-foot syndrome risk should receive a standard dose of capecitabine. Now, we incorporated the cost of the test, ToxNAV, that we got through an expert opinion, and for all the groups you see here, the reduced or the standard dose of chemotherapy, depending on their risk, we had a separate cost that we built into the decision tree and subsequently into the Markov model that I'll show in a minute. So this is about cost and effects. Compliance, you see that there's a tiny bit of a line out there in testing strategy saying no testing. So if clinicians did not, the patients did not consent to the test, and they were not tested. And there were just a couple of patients in that were not tested. And so we're building compliance also in terms of assigning patients to reduced or standard dose of chemotherapies. And we tested the managed entry agreement subsequently in a budget impact model. So this is the Markov model that's the same for the testing and the non-testing strategy. So every patient starts in the metastatic breast cancer, stable disease, and can progress or can die from disease or other causes. Now, results for the UK as well as for the Netherlands and for Hungary, we can see that the DOCSNAF strategy was less costly but more effective than the standards of care, and thus that was the dominant strategy. And from the cost effectiveness plane, you can see that we're very certain that that's the dominant strategy. In the Netherlands and Hungary, the DOCSNAF strategy is also found to be cost effective, and the gain in quality adjusted life years is similar, and that's partly due to rounding and secondly due to the utilities for metastatic breast cancer being quite close between the countries. And in the Netherlands, we saw savings similar to the UK, but there was an additional cost to a patient's lifetime in Hungary. Still, the DOCSNAF strategy was cost effective in both countries. Now, that's the budget impact model, and the ones you see are just reflecting the results for Hungary, and only for Hungary because we wanted to test whether introducing managed entry agreement with 75% of the tests in the quarter 50 year can actually have an impact on cost, and you see a reduction in cost subsequently. So to round up with some take-home messages, building in compliance can affect costs and outcomes. Capturing downstream costs and effects should ideally be done at every cycle of treatment of the model. And managed entry agreements can be tested not only in the cost effectiveness, but also in the budget impact model. Happy to take questions.